So I want to start by thanking each and every one of you for everything that all of you do each and every day to impact patients, clients, and residents within your own organizations. I don't get a chance to do this often in the midst of all the different providers across all the geography. This is the one event really per year where we bring you all together and have the opportunity to sit in one place and talk about this. So again, I want to thank you for all the things that you do each and every day to impact patients, clients, and residents. I just want to take the next few minutes and give you some reflections from the Southwest LHIN. I think that Frida and Mary Ellen's stories really provide some insight into the significant challenges that people face as their own health declines or as the health of one of their spouses or family members declines. And it also highlights the impact of not only the challenges they face, but also the positive benefits that they receive from the system itself. And this is something that I really learned from Frida. In the Southwest LHIN, we have our board meetings. We move around every month to a different community within the Southwest LHIN. And every second meeting, we have engagement sessions. So we have an engagement session with health service providers, health service provider board members, and then a second engagement session in the evening of that board meeting with the public. And at those public sessions, we try and bring in health service providers from that community to talk about some of the positive things that are going on in healthcare within that respective community. But in the last year and a half or so, we've also been bringing in clients, patients, and residents to talk about their stories. And that's where I met Frida. So Frida was the presenter at our community engagement session that took place in Komoka. And I met her for the first time there, and she came in and just some, informal greetings, and she said, well, I'm a little nervous about talking tonight. And she said, I've had a couple of sleepless nights thinking about this. That community engagement session in Komoka was 25 people. So in front of 500 people today, Frida, you did a fantastic job, and I should be commended for what you're doing. And to Mary Ellen as well, these patient, client, resident stories are so powerful, and as I said, emphasizing the challenges they face, but also the benefits that they receive through the health care that all of you provide as organizations across the Southwest LHIN. Frida, the disease that Nick has been afflicted with, Frida calls it a nasty, nasty disease. And it truly is in terms of how, in speaking with Frida over the last number of months now, she said that Nick took care of her for the first 46, 47 years of their marriage. And now the tables have completely turned, where she is taking care of Nick. So the dynamics within family relationships, beyond the healthcare issues, the dynamics between family relationships, spousal relationships, are really key in ensuring that we see holistic healing for the provider and for the person that's afflicted with the illness. We also heard from Stephanie. Stephanie was I'd say young woman whose mother was afflicted with Alzheimer's disease. Stephanie community engagement session in Owen Sound, and she spoke about the work that she's had the pleasure of working with the Alzheimer's Society Safely Home program that gives some respite to her father as her mother's responsive behaviors and some of her anxiety and aggression became more and more pronounced. The interesting part of that conversation, again, was around family dynamics. So here's I don't know, I shouldn't say Stephanie's age, I don't know what it is, but 30-something lady, and the difficulties they had trying to figure out the care for their mother, the relationship with her father, the relationship with her brother and sister, who's making the decisions, what decisions to make. So we need to bring all of that into play when we're making the decisions. We as health service providers within the system are making those decisions for those people afflicted with these illnesses. So as I said at the start of the day, we have structured the design of our symposium around our integrated health service plan. I hope you've had the opportunity to review the plan. If you haven't, inside your folder, there's a laminated card which shows our strategic directions and also shows some information about some of our big dot indicators. And I hope that you'll be able to pin that up in a prominent place in your office or in your workstation to ensure that you recognize what those directions are for from the Southwest LHIN perspective and how you can actually incorporate those into your work within your own organization. The IHSP was developed with a considerable amount of consultation and planning. We had 24 health service provider stakeholder meetings, 8 public meetings in every corner of the LHIN, online surveys, webcasts, and an online discussion guide. And you can see the title of our IHSP is Living Healthy, Independently, and Safely at Home. So what does that mean? How are we going to accomplish this? And better yet, how are we going to measure whether we're actually successful in achieving that? So how do we know that we are going to have people living healthy, independently, and safely at home at the end of this 3-year IHSP? So we have 4 strategic directions. First one is to improve access to family health care. The second one is to improve coordination and transitions of care for those most dependent on health services. So that's the significant focus of this direction, is focusing on that 1% of the population that consumes 34% of the resources, or as Saad Rafi said this morning, 5% of the population that consumes 66% of the health resources. The third strategic direction is driving safety through evidence-based practice around falls prevention and wound management, and you're going to hear about the great work that's going on in Grey Bruce with falls prevention this afternoon. And finally, increasing the value of our healthcare system for the people that we serve. We also have 3 key drivers, and one is technology. Technology, as I say consistently, technology has the greatest potential chance of making a positive impact within the system. So with advancements in technology, we can advance how healthcare is, how the healthcare system is transformed within the coming years. The other 2 key drivers are quality and value and connecting and empowering people. But to do this, we've created 3 big dot indicators. So what are big dot indicators? We can measure all the finite pieces of healthcare in terms of specific measurements and indicators within the system. But we've created 3 big dot indicators to measure system performance to determine how well we're doing within each of those areas. So those 3 big dot indicators, the first one is increasing the availability and access to community supports of people, resulting in 7,100 more days at home. So we're going to increase community supports for people, allowing 7,100 more days at home. Second one is increasing the availability of family health care. And the third one is reducing 15,000 emergency room visits and hospital readmissions, resulting in 10,000 more days at home. So we are going to be implementing a number of measures across the Southwest LHIN, which I'll talk to some of them briefly, and from that, measuring the success to ensure that we can keep more people at home living independently, healthy and safely. How will we do that? We want to reduce the number of hospital readmissions. We want to reduce the number of ALC patients, alternate level of care patients within hospital. And this isn't just a hospital measure or a hospital exercise. Those 2 measurements, hospital readmissions and alternate level of care patients, that requires coordination amongst all the sectors, all the parties within the system. Primary care, hospitals, long-term care, home care, mental health and addictions, and community support service agencies. Now, with additional investments from the LHIN in Home First, expansions in adult day programs, assisted living and supportive housing, we do intend to make a difference. But the implementation and success of these programs will mean cultural changes, process changes, and new tools. And no single organization can achieve meaningful change in the system alone. You heard the Deputy Minister say today that within the 2013-2014 budget, the hospital sector increases were frozen at 0. But the community sector increase has now been provided with a 5% increase. So that's 1% higher than it was last year when it was a 4% increase. This is a deliberate shift. And when the minister's here this afternoon, I'm sure she'll talk about this deliberate shift. Hospitals provide such an important care for patients, but the government has signaled its intention to provide more and greater care within the community. And although there's an economic driver behind this, of that 5% increase on community and 0 on hospital, it will mean more care at home where people want to be. The 4% increase last year was provided to the LHINs at our discretion to allocate to our community providers. We did have the option at the Southwest LHIN to allocate that 4% increase across the board. So every organization got a 4% increase. Their base budget was increased by that amount, and they would continue on with the services that they were providing. But we knew, based on our work that we've done around access to care, our community capacity report for mental health and addictions, that we need to flow the resources where they're needed most. So the LHIN board decided to target that investment to particular initiatives and programs, and the across-the-board increase did not happen. Didn't make us entirely popular with a number of organizations, especially considering the organizations that did receive that 0% increase. But it's important that we are putting money where it's needed to get the greatest value out of the healthcare system. Another one of our strategic directions is the improving coordination and transitions of care for those most dependent on health services. So as I mentioned earlier, this is the 1 to 5% of the population that consumes such a large amount of the healthcare resources. The composition of that 1 to 5% does vary across the province. It varies even within our LHIN. It could be a population with COPD. It could be congestive heart failure. It could be mental health and addictions. It could be frail seniors. But we know that success in treating and caring for those patients that are clients and residents that are within that 1 to 5% does require coordination and connection amongst all the providers. And health links are really laying the foundation for that. You'll hear about health links this afternoon with our first health link here in the Southwest LHIN through here in Perth, talking about some of the directions that the health link is taking to ensure that we've got collaboration and coordination amongst the providers. But as the system shifts, so as this direction of the government to shift resources into community and hold hospitals at the flat line, it does require that partners need to work more collaboratively to support people in their healthcare journey. And I had the opportunity to speak to the CCAC partnership meeting at the start of April, just last month. And I said the same thing to that group as well, is that I would strongly encourage all of you, the next time that you're frustrated with a handoff or frustrated with a lack of handoff, not to complain to your colleague, not to complain in the parking lot, but to reach out, talk to that partner, and determine how you could work better together next time. The LHIN is looking to all of you to ensure that those handoffs happen in a much better fashion, and we want to ensure that we can provide as much help with you. So we need your feedback. Anything that we can do to ensure those handoffs are handled better or more appropriately, please let us know. I'd just like to switch gears a bit and talk about the senior strategy. I'm sure you've heard about Dr. Samir Sinha's senior strategy. He was appointed as the provincial senior strategy expert lead in May of 2012. His appointment for the government was made in part because of the fact that seniors account for only 14.6% of our population, but nearly half of our healthcare spending occurs on their behalf. So it's 14.6% of the population across the province, but nearly half of the healthcare spending is on that seniors population. What Dr. Sinha found is that Ontario's networks of programs and services for seniors is highly complex, with a different set of services organized, delivered, and communicated by different ministries and providers. There's no one overarching framework to guide or coordinate this activity, making services confusing and difficult for seniors to access. As part of his work, Dr. Sinha visited the Southwest LHIN. He visited actually all 14 LHINs across the province. So back in September of last year, he had a visit to McCormick Home, the Alzheimer Outreach Services at McCormick Home, and then had a meeting with a number of health service providers at the community center in Komoka. At that meeting, Minister Deb Matthews also joined us, and she was there for the majority of the afternoon. So she heard some of the directions that Samir is hoping to head and has headed now with his recommendations. But what was really striking to me is that in the conversation with Dr. Sinha is that the health service providers within our LHIN and health service providers in the other 13 LHINs had already embarked on a number of initiatives to ensure that we're caring better for our frail seniors within the population. And his recommendations, now that they're out, have really helped to reinforce the work and directions which LHINs and all of you as health service providers have taken to assist our seniors living in our communities. On the technology front, I mentioned it at the start of the day, talking about Connecting Southwestern Ontario. Connecting Southwestern Ontario, and you probably have heard it referred to as CSWO, is an initiative that's funded by eHealth Ontario, but it's really the first steps to getting towards an electronic health record within the 4 LHINs within Southern Ontario. And I know you've heard it before, that we're moving to an electronic health record. We're going to get there by 2015. We actually have some tangible implementation direction to ensure we're implementing Clinical Connect, which is a viewer which allows you to view different healthcare records across the different sectors, and then Spire, which is allowing hospitals to transfer hospital information to family physicians electronically directly into their EMR. So CSWO is led by London Health Sciences Centre, which provides the overall direction and accountability for the deliverables across the 4 LHIN area. And when I say the 4 LHIN area, it's us, Erie St. Clair, Hamilton, Niagara, Haldimand, Brant, and the Waterloo Wellington LHIN. And then there's 4 individual delivery partners, one in each of those LHINs. And in our LHIN, the delivery partner is the Southwest Community Care Access Centre. So you'll hear more and more about this as we start to ramp it up. But this has got great potential for ensuring that we've got better information flowing between, and this isn't a hospital-centric system. This is a system-based system that allows the connection of providers across all the different sectors, including primary care. Just before I wrap up, I wanted to talk about integrations. We've had a number of integrations happening within the Southwest LHIN over the last year. A number have been completed, a number of them are underway. And I want to recognize the work of one of those integrations, which the LHIN has been involved with, and that relates to and we're calling it the amalgamation of Watch, Search, CMHA, London, Middlesex. So these are community mental health and addictions providers in the London, Middlesex area. Progress at the start was very, very slow. I think people were trying to figure out the relationship between the providers, building trust amongst providers, but that work is now accelerated in the last few months, and they have every intention of moving towards amalgamation of those 3 organizations by this fall. These integrations are not for the faint of heart. They take strong board governance, which we've had from this example, strong leadership to bring organizations together. How do you have conversations with your staff when you're talking about an integration with another organization? Very challenging conversations, sometimes when the conversation can't be public yet, that it needs to be kept at the table discussion with the amalgamation. But it does take patience, it takes trust and respect, it takes money to actually have this happen. But most importantly, it takes every one of those providers to be able to take off their provider hat and put their hat on of the client, patient, and resident. We can't look at what's best for the provider or the organization. We need to look at, if we bring these organizations together, how can we actually provide better care for the clients, patients, and residents that will be affected. And the minister often talks about her 2 questions, and I heard her say it again. Sandra and I actually heard her speak this week in Toronto at a meeting we were at. So looking at these integrations, the first question, is it better for the patient, client, or resident? And the second question, is it better value for money? So these are the very basic questions we need to look at to ensure as we move forward with integrations that are already taking place, but integrations that may be on the horizon or maybe just in the discussion stage. If the answer to both of those questions are yes, then you should continue to have that conversation to see where we could take it. I'd also like to recognize the great work of the 3 hospitals in the County of Oxford with their joint services planning work. A great deal of work has transpired there already, and we are looking forward to working with them over the course of the next months. So I just want to conclude by talking about public trust. As leaders in the health system, we are assigned a tremendous responsibility for ensuring the public has trust in the Ontario healthcare system. Jeff Lowe, our board chair, and I were asked to testify before the Legislative Standing Committee on Social Policy on the chemotherapy issue. So you've heard about it in the media, I'm sure. The committee called numerous witnesses to testify. In the end, it became very clear that the Southwest LHIN, or the 2 other LHINs that were called to testify, didn't have a lot to do with this issue. But there was a common theme in the questions that were asked by the MPPs that were part of this committee. And the question that they asked was around public trust. And in reference to the chemotherapy issue, the MPPs asked what role the LHIN should play to ensure the public continues to have trust in our healthcare system when that trust is shaken by by a situation like the one we've had with chemotherapy. And I think the answer to that question, and my answer probably wasn't as elegant as I wanted to at that committee meeting, but it's really in ensuring it's not so much in what we say, but rather what we do. And Paul, you referenced it this morning when you talked about, you can only see value through behavior. Trust is a value that we need to ensure that the public has within the healthcare system. We'll always be faced with media reports, commentary from other groups, community groups, that'll paint us in a negative light, and sometimes it's deserved. But we do not want this information to overshadow the great work that all of you, all of us do, and the great care that's provided in our institutions and by our providers every day. It's incumbent upon all of us to ensure that we act in a manner that will solicit trust from the public we serve. And there will be instances where we'll fall short, where we did not deliver the level of service or the level of care that we had hoped or as expected or required by the public. But it's in these circumstances where we need to rise up and address these shortfalls. It's in these circumstances where we need to address issues in an open and transparent fashion. And a comment that I make commonly is that we need to fail forward. If there is a shortcoming, we need to fail forward and look at how we improve from that. But it needs to be done in an open and transparent fashion. And finally, I think we can talk about our successes, our organizations, you can talk about your successes, but we do need to hear from patients, clients, and residents. I think first of all, we have to listen to patients, clients, and residents. But then secondly, we need to ensure that the public has an opportunity to talk about the great work that all of them have experienced within their interaction with the healthcare system. And I think you heard it from Steve Paikin today. He was trying to get out from Mary Ellen and Frida about, did you really have to complain about something to get it, or did you have to get ugly about it? And maybe it's just the disposition of Frida and Mary Ellen, but we heard clearly that they didn't. It's about communication and setting expectations. So we need to continue to ensure that we focus on ensuring that public trust in the Ontario healthcare system remains. So just to wrap up, I believe that the IHSP provides a collective direction for our local healthcare system for the next 3 years. I'm glad to hear that the Deputy Minister agrees that it's in alignment with what the Ministry is proposing to do as well provincially. But implementation of the strategic plan relies on the collaboration and leadership of our health service providers. The IHSP outlines numerous collaborative initiatives amongst primary care, community-based care, long-term care, and hospitals to provide sustainable improvements in high-quality care. We are very fortunate, and I, on an everyday basis, am very thankful for the strong system leaders that we have within the Southwest LHIN geography to collectively advance our priorities. And I feel very optimistic. I said at the start about the optimism meter. I feel very optimistic that we will achieve success if we continue to put the patient, client, and resident at the center of the system and create a system not built for providers, but create a system that's built for that patient, client, and resident. Thank you.